Hello everyone, my name is Michael Semanek from the Perlman School of Medicine, and today I'm presenting a case study on superior sagittal sinus stenting for idiopathic intracranial hypertension, or IIH. In this presentation, we will explore the evolution of this intervention from the patient's clinical presentation through diagnostic evaluation and ultimately discuss the decision-making that led to stenting. I'll also share the outcomes, risks, and key takeaways from the case. Let's begin by reviewing the learning objectives for our discussion. Our objectives for today are as follows. First, we will review the patient presentation along with detailed history and symptoms. Next, we'll discuss the diagnostic workup that confirmed the diagnosis of IIH. Then we'll examine the cerebral arteriogram findings, including the identification of stenosis, and discuss how the decision to proceed with stenting was reached. I will also cover the rationale behind venous stenting, the associated risk considerations, and wrap up with key clinical pearls and conclusions drawn from this case. These points will help us understand both the clinical nuances and technical aspects involved. Let's start with the patient presentation. Our patient is a 34-year-old female who initially presented with a complex history of persistent headaches and associated pain. Specifically, she experienced a 5-year history of nearly constant photosensitive headaches that were primarily localized to the occipital region and right forehead. She also reported significant neck pain, which was exacerbated by movements such as flexion or bending, and more recently, she began to experience lower back pain. She has been seen by numerous different physicians, from neurologists to pain specialists, yet her symptoms persisted despite multiple treatments. This background set the stage for a deeper evaluation and ultimately a more advanced intervention. Her physical and neurological exams were unremarkable. She had no significant past medical history or surgical history. Really, the only thing of note was several years into these headaches occurring, the patient had started on Wegovy and lost a considerable amount of weight, but noticed no change in her symptoms. Moving on to the diagnostic workup. Given the persistent and disabling nature of her symptoms, a comprehensive diagnostic workup was essential. This involved a combination of non-invasive imaging studies and invasive diagnostic tests. The aim was to rule out secondary causes for her symptoms and evaluate intracranial dynamics. All of the patient's prior imaging showed no definitive explanation of her symptoms, which led to a trial of empiric treatment with acetazolamide on suspicion of IIH, which provided mild symptom relief for a few months. Due to this symptom relief, a laminar puncture was performed to measure the opening pressure, which was substantially elevated for a relatively young and otherwise healthy patient at 26 millimeters mercury, which further pointed toward a diagnosis of IIH. This ultimately led to the order of a cerebral venous angiogram and manometry to assess for any stenosis and pressure gradient. So let's just review IIH in general. IIH is characterized by elevated intracranial pressure in the absence of detectable cause on neuroimaging or CSF analysis. It most commonly affects women of childbearing age and is often associated with obesity, though our patient's lower BMI and still persistent pain and headaches reminds us that this can be a variability in presentation. The condition may present with symptoms such as severe headaches, visual disturbances, and other neurological deficits. Given these factors, early and accurate diagnosis is critical to prevent irreversible complications such as vision loss. Our patient's atypical presentation underscores the need for careful consideration, even when classic risk factors and symptoms aren't fully present. This slide highlights the key finding of high-grade stenosis in the superior sagittal sinus. The imaging and pressure measurements indicated a significant discrepancy. A pressure of 22 millimeters mercury above the stenosis compared to just 14 below. A gradient of 8 millimeters mercury. This clear pressure gradient confirmed that the stenosis was hemodynamically significant and was likely contributing to the increased intracranial pressure in the patient's symptoms. The presence of this gradient was the tipping point for considering a targeted intervention. Now, looking at the intervention itself, we see a side-by-side comparison of the pre-intervention and post-intervention states. Prior to stenting, our imaging and pressure measurements clearly demonstrated the abnormal pressure gradient across the stenosis segment in the superior sagittal sinus. After the stent placement, there was a notable improvement in pressure dynamics, which correlates clinically with symptom relief. In essence, the stent served to restore normal venous outflow, thereby reducing the intracranial pressure and alleviating the patient's debilitating headaches. This visual comparison underscores the efficacy of this approach in selected patients. So in the discussion of this case, I want to focus first on the rationale for venous sinus stenting. The primary goal in treating IIH is to relieve the increased intracranial pressure. Traditional therapies such as medical management or repeated lumbar punctures often provide only temporary relief, as was seen in our patient's case. Venous sinus stenting addresses the underlying venous outflow impairment, restoring normal cerebrospinal fluid absorption dynamics. Although most cases involve stenting the transverse sinus, this patient's anatomy and the pressure gradient in the superior sagittal sinus made it an ideal candidate for SSS stenting. This approach is both innovative and highly targeted, allowing us to tailor the treatment to the patient's specific vascular pathology. So, of course, no treatment comes without risks, and it's crucial to understand these when considering venous sinus stenting. The procedure is associated with several potential complications. These include the risk of venous perforation during stent deployment, stent thrombosis, and the possibility of subdermal hematoma developing. Additionally, there is a risk of restenosis. Some studies report rates between 5 and 10%. Because of these risks, patients are typically maintained on a strict regimen of antiplatelet therapy following the procedure, initially dual therapy for 3 to 6 months, followed by long-term monotherapy. Thorough pre-procedural assessment and strict post-procedural monitoring are essential to mitigate these risks and optimize outcomes. So for our discussion today, there are several key takeaways. First, the identification of a significant pressure gradient across the stenosis in the superior sagittal sinus was pivotal in determining the need for intervention. Second, the use of venous sinus stenting offers a novel and effective treatment option for medically refractory IIH, especially in patients whose clinical and anatomical findings justify this targeted approach. Finally, while the procedure is promising, it demands careful patient selection, meticulous technique, and diligent follow-up to manage potential complications. This tailored anatomy-specific approach is indicative of the evolving role of interventional radiology in neurovascular disorders. So let's review some clinical pearls that emerged from this case and the associated lit. First, early detection of IIH is critical. This includes a high index of suspicion, especially in patients with subtle findings such as mild papilledema. Second, a comprehensive diagnostic workup, including MRI, MRV, and lumbar puncture is essential, but the integration of invasive manometry can provide decisive information regarding the hemodynamic impact of a stenosis. Third, the identification of a transsonic pressure gradient above 8 to 10 millimeters mercury is a strong indicator for the potential benefit of stenting. And finally, successful management of IIH often requires a multidisciplinary team, including interventional radiologists, neurologists, and neuro-ophthalmologists to achieve the best outcomes. So in conclusion, this case study reinforces several important points. We saw a classic, but somewhat atypical in some ways, presentation of IIH, where the patient's persistent symptoms were ultimately linked to a hemodynamically significant stenosis in the superior sagittal sinus. The use of venous sinus stenting not only improved the pressure gradient, but also resulted in marked clinical improvement. This case underscores the importance of personalized anatomy-specific interventions and the expanding role of interventional radiology in managing refractory neurovascular conditions. I hope this discussion has provided useful insights that can be applied in similar challenging cases. Thank you for listening. And here are some references I used in the creation of this presentation.